Well, good morning, everyone, and welcome to our Grand Rounds. I know this is the start of the academic year, but this is an unusual year because we're starting at a time where Houston is recovering, and I know many of you have been either affected directly, or your loved ones, or your friends, or your neighbors have been affected by this devastating storm that has hit the Houston area. And to tell you the truth, I thought about maybe postponing this Grand Rounds, but this is part of getting gradually to normalcy and getting part of this healing process, which is we're an integral part of it. It's taking care of patients and thinking about somebody beyond us, thinking about our patients and our community and neighbors. I was away during the storm. My wife was alone, stranded. Luckily, as some of us here, we were not directly affected. But I can tell you that this storm, with all its devastation, brought the best in Houston as almost a role model city where the community gets together to help each other, help the neighbors, be it financially, moral support, or whichever way support is. And I can tell you, I was at the European Society of Cardiology, and the coverage was not only of the devastation of the storm, but what the Houstonians and other people in the community or beyond the community came to the rescue and to the support of people in our community. With that, I think gradually we'll start back to normalcy. I want to thank and acknowledge the people who really have helped our patients here at Houston Methodist and the Ride Out team. People have spent days here, at times risked their lives to come here and take care of our patients. So, if you don't mind, I'd like to recognize the people who really slept and took care of patients here. And this is not only the physicians, this is also all the healthcare professionals, the nurses, nurse practitioners, technicians, whoever. I mean, for our cardiovascular community, I think we have a large patient population here. And from the cath lab to the physicians to the nurse practitioners to whoever was involved in the imaging laboratory. It is amazing that we're up and running within just a few days of the storm. So I would like the people who were here, who wrote it out, to stand and be recognized for their heroic and selfless ways of really helping our patients. So could you please stand? Well, we're back to more mundane things, believe it or not, and it looks more mundane. I thought of maybe at the beginning of the year to, rather than talk about a specific issue in cardiovascular care, to talk about where we are. Cardiology, healthcare, some of the challenges, opportunities. I know we deal, each one of us, with our own patient population, our patients that we take care of. Others have a little more wider view, particularly when it deals with research and planning other things, and others have a little more global view. So I wanted to give you a feel of where we are and what is the environment nowadays. And you feel it, but I think it's good for us to sit down and talk a little bit about what are we facing and what are some of the challenges and great opportunities. And I will end it actually with a list of where people are thinking we're going in the next 10 years. So yes, we have divergent health issues. Obesity is a major issue. We'll talk about that. Lifestyles, comorbidities. People are living longer, but at the same time, that also adds to the complexity of our healthcare delivery. Us, the practitioners, yes, we are facing issues Electronic health record is not anymore in the vision, it's here. And we have to deal with it one way or another. It is complex. However, there is burnout, and actually there will be a grand rounds this coming year about burnout of physician and healthcare professionals in many ways. Healthcare reform, ACA, with a big question mark, almost derailed, I would say, with just one vote. Globally, there is rise in cardiovascular disease, while we think at home that we have it much better under control. And there is this advancement and excitement in science. And I was at ESC, and those of you who were at the ACC, and every meeting that we go to, there is actually tremendous advances. We think that we plateaued, but there's no plateauing. We'll share with you a few of the things that I saw at ESC. So what I want to do is a quick, really overview of where we are in training. I know people have asked about MOC, a little bit on science, practice, some global trends in the future. One, as our training programs, for those of you who are going through training, the first 4 are approved already by ABIM accredited programs. Interestingly, and I don't see it changing anytime soon, that imaging is not an accredited program because of its complexity and so many societies involved in it, and ABIM position. Structural heart disease, I don't see it happening as a separate one, at least as of yet, but it will take some time for it to gel. And we pride ourselves that we have actually all these accredited programs, advanced programs, and non-accredited programs here up and running. And we have currently almost 15 fellows in advanced, and will be close to 15 fellows in regular basic training. People talk about maintenance of certification and how do we go about certification. As you know, over the past 2 years, there have been major changes, an uproar against ABIM regarding requiring both a 10-year examination as well as the new maintenance of certification. ACC has done a tremendous job actually in lobbying the ABIM and changing a few things. One is that Part 4 is suspended. There will be ultimately down the line, you know about MOC and Part 2 credit, but there will be an ABIM a 2-year alternative to a 10-year examination starting in 2019, and there is also a proposal from ACC still under discussion with them, and I'll share that with you a little bit. So nowadays, if you go to the ACC scientific sessions or many of the programs, you will get both CME and MOC. If you go to the JACC journals, you can get MOC and CME. So basically, you can get your requirements of credit to MOC by either going to the journals or going to the face-to-face meeting in scientific sessions. Interestingly, ACC is only one of three societies, ACP, which is the American College of Physicians, ASCO, the Cancer Society, working to develop with ABIM alternatives to the 10-year program. There's a proposal from the American College of Cardiology that I saw a few months ago, which is called Society Maintenance Pathway. It's a yearly module that you would take in different areas. And I think that's a proposal instead of the 10-year examination. So you stay, up to speed as to what the science is, and do that for each module once a year, alternating module, and that will keep changing, keep repeating itself every 5 years. The science is amazing, and it really is amazing, because the developments in valves, percutaneous valves, and this center has been a leader for that. Novel anticoagulants, and at the ESC there was a presentation on the use of anticoagulants with antiplatelets for prevention of mortality and events. New heart failure, new VADs, new approval for HeartMate 3. LAD occluder devices, PCSK9 inhibitors, a landmark really trial just presented at anti-inflammatory agents, just targeting antibodies to interleukin-1 beta, just showing by itself that it changes the prognosis of patients with coronary artery disease, and at the same time decreases and delays cancer development, and without changing anything in lipids or any other risk factors that we know of, which is really a new landmark area for research. Regenerative medicine, enhancing longevity. A recent study from Dr. Cook, our own Dr. Cook, in JACC, looking at changes or enhancing or lengthening the telomere, hopefully for increasing longevity. And imaging technologies have been really amazing. As you may or may not know, we have an agreement now with Siemens to have really a major project, even with a 7T magnet at the Research Institute, as well as PET programs and so many other things, and physicists here on board to try to enhance our diagnostics as well as therapeutics. Now, you may be overloaded, and I know you are. I am overloaded with information. Many journals. I haven't seen any attrition of journals yet, but more and more journals. Now JAMA is on board, cardiology as well as basic sciences, JACC. So you have to deal with that. You have to deal with how do you organize yourself and get the information you need. You may be on social media, and I am, and you have to navigate it well, because otherwise it can be consuming. But at the same time, it can be really amazing in areas that you usually do not tap. Areas that will affect either healthcare in a way. I follow a few people. Eric Topol actually is quite a bit involved in newer modalities and technologies and wearables. So if this is, and there are many other areas that you could decide who to follow, but make sure that you're not consumed, because it can really consume you. So I just warn you there. But the rapidity of the information is amazing, because journals nowadays, in addition, actually tweet their most important articles. So you could see the uptake is before even getting the journal and reading about it, because it has links to the various things. And I don't prescribe to Cell or Nature, but I can tell you, I can see the most important ones that are affecting cardiovascular disease. So I would urge you, one way or another, to connect. I don't know how many people are on Twitter. Can you raise your hand if you are on Twitter? Okay, well, 2 years ago when I gave something similar, there were no hands. And you will see, more and more people involved, because that's one way to rapidly communicate and get some thought leaders to engage with you one way or another. It is a mobile world. ACC now has an amazing array of apps. We cannot live nowadays without apps one way or another. It enhances our availability for knowledge, our decision making at the point of care. And you can have that for anticoagulation, for risk calculation, for so many other things, and we'll talk about. So what are some of our practice trends as well as national focus? The Affordable Care Act now is in its 7th year. 7th year. 7 years already passed. And yes, it was teetering on major changes. Has not happened, but the prognosis, you cannot really tell about its prognosis, knowing what the situation is politically. But I can tell you that it is unfortunate, I would say. It is unfortunate that the healthcare debate has been politicized. In most other countries, actually in almost all countries, it is a matter of health. It is a matter of economics. What are your priorities? Where do you want to spend your dollars, as opposed to a political stance? And I do hope that we change this dialogue. It is hard, but I really do hope we change that dialogue to think about patients, coverage, that's a talk by itself as to, how do you cover your population of a particular country? Certainly, we don't pair well with coverage in any other of the developed nations. Just to show you what the ACA has done over the past 7 years. Basically, we knew very well that it's much more access to insurance and therefore access to care. And these are the trends in the population in healthcare insurance. Those people who are insured, either private, and you could see that the vast majority is through employment, up to 70%. The public is about almost 20% in green, and part of that increases through Medicaid, obviously. The most important thing, at least to us in healthcare, is how many people are uninsured. And it's down to almost 12% from close to 20+%, and therefore 23 million fewer uninsured over the past 7 years, and I think practically over the past probably 5 years. I think that's important because then individuals don't have to worry about major bankruptcy as opposed to before. Now, interestingly enough, if you take a look at the percent uninsured by either age, race, or financial situation, take a look at age. The people in green, which are the least uninsured, are the ones that are about Medicare age, which basically guarantees you health care. And as you would expect, the younger individuals are staying uninsured, about 15 to 16%. They have to make a decision whether to get insurance, yes or no, and basically a financial decision. Interestingly enough, you take a look at race. Hispanics are about now, they used to be close to 50% uninsured in this country. Now they're about 25% uninsured, and you could see the other spread. But also importantly, take a look at the financial. Near poor or poor individuals in this country, about a quarter of them still uninsured, don't have access to care, while the people who are faring better, their uninsured rate is about 6 to 7%. That tells you about the magnitude of the issue we have in this country going forward. Now, I've shared this with you if you were here in 2008 and thinking about the projections, certainly unsustainable because the growth in GDP, percent GDP for healthcare was incredibly high, right? It was high, it's still high, certainly by magnitude compared to our next country in the United States, in the world. But those projections have changed because if you take a look at the past few years, the cost and the spending into healthcare has slowed down significantly. Now, we don't know what the forecast is after a few years. We know that insurance companies are gradually raising their rates. So yes, the ACA addresses access to care, but not necessarily the cost of care. And I think that's a big discussion going forward. And if you take a look at the cost projections in the Medicare population, this was in 2006, going almost exponentially. And as the years passed, you know, the cost projections per beneficiary have gone down. We don't know what it looks like going forward. Now, people have blamed it initially on the recession, but it's really not only because of the recession, as you could tell. There is a recovery over the past few years, and still these trends are the same. Now, part of that is actually the other side of the equation is we were, as a healthcare system, a pure fee-for-service without even looking at a value, cost effectiveness, outcome for many, many years. And I think that's becoming part of the equation nowadays. And you know that will be part of the payment models, is to take a look at what really is cost effective, what is ultimately the best way to treat patients and the most cost effective way with a good outcome. But part of the discussion, and these appropriate use criteria, believe it or not, came not only from an ACC perspective, came from the payer's perspective also. The payers came to the American College of Cardiology and said there is overutilization of many of these resources. Let's try to work together, and we'd like you to do something about it and talk about appropriate use criteria. They're onerous in a way. Vast majority were mostly for testing because there was perception that there's overutilization. Actually, there is overutilization of imaging technologies, but gradually into therapeutics and revascularization and ICD placement, et cetera, they're onerous in a way because it's very hard to navigate it. You may have tools to try to help you. Actually, in 2019, we'll talk about it. You can't order an echocardiogram or a nuclear stress test or a PET without justifying the reason to do it. And hopefully it will be part of appropriateness. Yes, it's a little more onerous on us, but this is the trend in utilization of cardiovascular imaging. I've shared that with you before. It has gone down, and we will see what it would look like down in the future. Top issues for cardiologists nowadays. Traditional payment is no longer there, and you will probably see it and feel it probably close to 2019, if not already. New payment models, MACRA, bundling, ACOs, This institution has an ACO. You may not know about it. Bundling, we have not been hit. Houston has not been hit, but other cities have for coronary artery bypass surgery and the care of an acute coronary syndrome. Electronic health record, you are expected and you are already measured. Now, if you think this is a bit intrusive, just look at our life nowadays. You are measured, actually you're tracked in whichever way you go. That's how people know about your traffic. That's how people know about so many other things. And Al Reisner came in today, he told me he's gonna spend about 2 or 3 hours on the road, and I appreciate it, Al, to come. But that's how we're tracked in so many ways. But actually there is more transparency, you can think about it. Access matters, when and how. Patient experience matters because you're gonna be paid also partly on patient experience. There's no relief in operating costs. And there are hospital relationships, new ones, and new employment models. Texas and the southern states, and less employment models compared to others, but it's catching up. In the north and northeast, almost some of them are 100% employed physicians and healthcare professionals. Now, we had a grand rounds on MACRA and payment models, but I just want to tell you a few things, that whatever you do now is being measured for projections on your payments and how you are taking care of patients in 2018, 2019, whatever you're doing. Because Medicare will take a look at your utilization, the processes that you're doing for taking care of particularly any diagnostics that you're doing for a particular condition. And you're gonna be measured on that, and you're gonna be forecasted on that and put into 2 categories. One, it's called merit-based incentive payment, or MIPS, where all the ones on purple basically will be compacted into a new payment model that has some value and so many other things in it, and that's starting in 2019, which is not too far from now. And we may want to put together just a symposium for you to know what this is about. I think it's very important. And the other is bigger organizations, and depends on your volume and your statistics, you'll be in this alternative payment model, advanced, that gives you a 5% bonus. Obviously looking at your total utilization, and in addition to utilization is really the outcome of those patients that you're taking care of. So yes, everybody talks about quality. And the payers want quality, the providers want quality, the patients want quality, policymakers, purchaser, everybody wants to talk quality, and it is difficult because yes, we have some measures of quality, but does really tell you about the true quality that you're providing that particular patient? You can't really measure everything. So we acknowledge many of the issues that we are dealing with, the new parameters that come on board for measuring quality. And you are being watched, as I said before. CMS is watching you, state health agencies, accreditation organizations, insurance companies, and the public. Now, is this, you have to be defensive? I really think personally, I never think about this. I really think personally, if you practice good care, engage the patients, practice cost-effective medicine, and don't layer one test on top of another, and another to be able to get to where you want, and have hopefully some coordination of care. This is where a major issue is fragmentation of care. I think you should be fine, because no matter what people measure you, you're gonna stand to reason. You're gonna stand that you're a good practitioner. But data is out there. If you haven't navigated this, I think you'll be surprised. This is old. Hospital Compare is old. This is in the governmental site where you could compare one hospital to another, et cetera, in whatever parameter you want to take a look at. Just go, besides Googling whatever it is that you want to do, just maybe Google yourself and find out what people are talking about you in healthcare. How many stars are you getting, right? And it's getting closer to what it is, but there's a lot of trash out there. It really is. I mean, it is very disturbing in a way. You can Google the top 10 cardiologists in the world, okay? And to tell you the truth, I never heard of them. So it just tells you the story. You could Google the top 10 cardiologists in Houston, in any other city. There are sites for all this, and there are commentaries. You know, I have no idea where they come from, but they're there. Now, here in our institution, I know the physician organization, you know, for primary care and other specialists are putting actually the patient's commentary out there on the web. So when you have your profile, you're rated, so you can take a look at actually what patients are saying about you. But I think for data as to our practices as a group, as a hospital, et cetera, really we have to go to much more objective data. And I think where we go to usually is the NCDR, which is the National Cardiovascular Data Registry. And I think this registry is amazingly robust because it is the largest registries and fleet of registries really in the world nowadays. And you could take a look at trends, benchmarks, you name it. 10 national programs, so I think this keeps expanding. 2,200 hospitals, 10,000 cardiologists, millions and millions of medical records that you could glean something from as to what's going on in the nation, in your hospital, compare it to others, et cetera. And I've shared this with you before, and this was a bit historic. And the reason for it is this is the first time where the FDA called the professional organizations to ask for help of how do you roll out a new technology that is expensive, that can carry a risk, and a collaboration between the FDA, which regulate, CMS, which pays, and the professional organizations, the ACC and STS, to come together and say, well, how do we roll this? And this is how these criteria for a center for advanced valve therapeutics came on board in the TBT registry, et cetera, et cetera. And then that has been the model really to roll out now, at least in cardiology, I can tell you, the other catheter-based technologies, which is mitral valve clip and LA appendage occluders. And these are the registries, and you could see the patient record on the right. Pinnacle, it is the largest outpatient registry in the world with 27 million records. Diabetes, that's a collaborative with the ACP. Cath PCI, the oldest registry, with 20 million records. ICD, Action, PVI, Impact. I mean, all these, basically quite a few of them are interventional. And the only one that is outpatient is the Pinnacle registry, which is an important one because then you can look longitudinally at patients, what kind of care they're getting, are we missing something, yes or no? And this is the Pinnacle registry, really amazing throughout the country. What does it provide you? And we waited, now we're on Epic, we're gonna hopefully get on Pinnacle, we're not yet on Pinnacle. What does it tell you? Well, it tells you what your dashboard is like compared to the nation. And we've learned nationally that patients with atrial fibrillation that need to be on anticoagulation, guess how many are getting anticoagulation? It's between 50 and 60%. So it really is amazing how when you open your eyes to data, the data really tells you about what the true story is like. And I don't have to tell you that data drives behavior. Data drives knowledge. And this is the story of Door to Balloon that was initiated through the ACC. And you could tell that early on in 2005 we were not doing as well. And over time, when you reported this and acted on the data and tried to figure out how the system works and how to improve the system, this Door to Balloon time improved significantly in the nation. The other thing was, and this is the largest registry of PCI interventions. Largest registry in the world. Total PCI, 500,000 people. 71%, and this was in 2011, now this has grown, but I'm showing this to you just to tell you how the behavior changes. 71% acute STEMI and 29% non-acute indications. That's in the registries. Appropriate PCI for acute indications, meaning acute myocardial infarction, is almost 100%. However, for people who are elective PCI, the inappropriate, at times inappropriate may be either lack of symptoms or not testing for ischemia, various other things. The reason for it is about 11.6%. And the interesting thing when you start having data is to look at the heterogeneity among hospitals, be it appropriate versus inappropriate. This is hospital rate of quote-unquote inappropriate PCI on elective situations, and you could see the spread in the hospitals that are reporting in this PCI. Now, when you report this, obviously, there are meetings. You look internally, and there are committees and people who are driving and the behavior. And take a look at what happened over time since the initial reporting. The appropriateness went up, and the inappropriates went down, and the uncertainty, those indications went down. So basically, we know that we are driven by data, but if you don't look at the data, you really have no idea where you are. Because everybody, each one of us thinks that we are doing the best that we could do, the best of care, but at times there are healthcare systems that affect how do you get to a particular patient. How effective are you in basically doing an acute PCI on somebody with a STEMI? I mean, it is not only the physician, it's the whole system that really drives this. And if you want to take a look at 4 of these registries, and this is a recent publication in JACC, the trends in cardiovascular care in the nation for cath PCI, ACTION, which is acute myocardial infarction, ICD registry as well as impact. You'll see it there, and I'll share just maybe 2 slides with you. One is ACTION. ACTION is the acute myocardial infarction registry. Look what happened over time from 2011 to 2014. Death is still about the same at 5.9 to 6.4%. Heart failure, maybe a little less, from 5.3 to 4.5% over time. But major bleeding also significantly decreased from 10.1 to 8.5% over the few years. And that's obviously reported at the hospital level, at everything level. And if you want to take a look at in the nation, what is the median time to primary PCI in STEMI? If you're not transferred from one facility to another, it's the lower bar. It's about 59 minutes, 57 minutes to get to a STEMI, PCI door to balloon, as opposed to a transfer about 100 minutes or so. Okay, so a little more than an hour and a half. For you interventionalists as well, hopefully electrophysiologists soon, actually there is an app. And there's an app that you could download it. It's called the CQC app. And it tells you about your own data as an interventionalist compared to national data, compared to everything else. I think it's an incredibly powerful tool to give you feedback. And if you're doubting the numbers and you're not sure, obviously you can go to the hospital, our abstractors, et cetera, and just contest that. But I think it's a great thing for you to be able to see your own data, and it will be coming also for electrophysiologists. So you could download this. This is our team. Our team, NCDR registry here at Houston Methodist, we are involved in the vast majority of these NCDR registries. Not here is not an NCDR as a get with the guideline heart failure. And you could see the names of people who are designated principal investigator, medical directors for this, from Barker, Kleiman, Valderrabano, Solomon, Kleiman, Reardon, McGilvery, Nasser, and for get with the guideline heart failure, which is not an NCDR registry, but is an HA registry, is Dr. Park. I cannot but thank so much Aurelia Ramos, who goes by Mimi, and a large team of abstractors who really are doing all the work to try to put this in action for us to be able to see our own data, your own data. And I think, at times it's a thankless job because they have to talk with you about documentations, but this is how we are seen, this is your data. And the more you help them, I think the better you stand, the better we all stand. And I'll share with you maybe 2 or 3 things. One, this is our own action registry over time, how we're doing. This is acute MI composite, closer to where we want to be in target, gradually improving. Discharge composite, meaning all the care that a discharge after an acute myocardial infarction. We're not doing as well, and particularly because the one on the right, which is cardiac rehabilitation. If you think we're the lone rider of poor performance, we're not. But certainly we made a dent with everything else that we've done, up to 40% from almost nothing. And this is a plea from the Million Hearts campaign, is they want to increase it from 20% to 70%. And part of the reason, you may or may not know that, is it would save about 25,000 lives and prevent 180,000 rehospitalizations annually in the United States. It is not a medication. It is not a device. But to tell you the truth, if you don't go to the gym and take care of your health, you know how you're going to feel. So just imagine our patients who have been through an acute myocardial infarction and so many other things. We don't know the mechanisms of what is the positive effect of exercise, and I think that's one of the visions for the future. But I really think this is really crucially important. This is for cath PCI, HMH. Proportion of elective PCI with prior positive stress test. Basically, you're documenting ischemia before, on an elective patients, before doing a PCI procedure, gradually increasing over time. And we share these with you at the service line meetings, so I cannot but ask you to come to the service line meetings, which are important. Median fluoroscopy time in minutes, gradually decreasing, and that's what you want. We're still not at the national benchmark, but I think we're getting there. The one on the right, composite, proportion of patients PCI with death, emergency CAB, stroke, or repeat target vessel revascularization, gradually decreasing, which is tremendous, certainly better than average. I think that's great. Now the last one, patients without acute coronary syndrome, proportion of evaluated PCI procedure that were appropriate. I think we're in the range there regarding appropriateness of elective PCI. Science indeed tells us what we can do, and this is the beauty of science. The guidelines, what we should do in a way, and appropriate use criteria, and the registries, what we are actually doing. And this is the only feedback for us as to how well we're doing individually, as a group, as a hospital, as a city, as a nation. And I think this is very important. And we're data-driven, and unless we have data, you really cannot act one way or another, at least in the most intelligible way and most informed way. Now, we talked about the top pyramid there, and this was the ACC strategic plan. I know they're working on their next strategic plan for the next 5 years. The triple aim, lower cost, better health, and better outcome. And education certainly is important. That's what we do, and this is part of these grand rounds. But population health on the left is also very important, because gradually you go from an individual to population health. And I think this is important. That's how we have to start thinking as a nation, to try to improve the health of the population in addition to the individual patient care that you take care of. I was very involved in the CardioSmart initiative when it was relaunched, when I was ACC president, and I feel very good that it really has taken foothold in so many ways. It is an initiative to empower patients and caregivers, support the doctor-physician relationship, and give tremendous information, not only for patients, but also for the care providers. And this ecosystem, no pun intended, is really in multiple ways. One, you can go on CardioSmart, and that's what I tell my patients. I said, if you want to be smart, go to CardioSmart. And smart, obviously, about their health, because it has pretty much everything that patients need for their own information. There's a CardioSmart TV that you see it here in our facilities that is, gives patient information to those patients depending on, and you could configure it whichever way you want. But the most important one for the providers, and many of you, be it physicians, nurse practitioners, whatever it is the one on the left lower, at least in my opinion, to try to explain things to patients. This is an app that I helped develop when I was president, and now, finally, it is available on an Android device, on an iPhone, on an iPad, whatever it is. And it's really amazing because you can think of any condition, cardiac condition that you want to explain to patients, and it's there. It's free, and it's called the CardioSmart Explorer. And that's the icon for it. And I think you could download it. And Al, I think it's the easiest PCI procedure you could do. It takes 20 seconds to deploy a stent and get your catheter out. For heart failure patients, for electrophysiologists with pacemakers and everything else, it really is amazing from a teaching point of view, and it is certainly better than my drawings when I try to draw things for patients, and they're pathetic at times. So for our allied healthcare professionals, there are brochures there, there are posters, I mean, you name it on the condition, they're really there. And you could see the uptake here. It's about unique page views, about almost 2 million in 2016. Visitors, 1 million and a fraction. And it really is a website that at least you know, you feel good about the information. And actually the editor of that CardioSmart is Dr. Martha Gulati, who gave grand rounds a few months ago here. And I think she's doing a tremendous job. It is the planet of apps nowadays. Unfortunately, this is coupled with a different situation, and it really is pathetic. I can tell you, this is pathetic. You can't even recognize the species that we are. We started about the same on the left, but you can't recognize our species because of tremendous obesity epidemic. And you could talk about why, but nowadays there are many health gadgets for patients, right? Each one of you has it one way or another. You like it or not, it's on your smartphone, it could be on your Fitbit, it could be on your watch, whatever it is, okay? The question is, what are you doing with it, and what's the impact of this? If you want to take a look at, this is text messaging, this is published in JAMA. If you talk about text messaging and lifestyle focused, to change your habits, et cetera, it had an effect on decreasing LDL cholesterol, systolic blood pressure, physical activity went up, and smoking also went down. The question is, how long do they last? Unfortunately, the data has shown that they don't last long unless you keep engaging one way or another. So we have to think about behavioral changes for our patients, and obviously our messaging is important for patients, and we have to engage with our community. I know us as a community have done quite a few things for community-based teaching. I know Kevin Lissman volunteers a lot for this, as well as many members of this DeBakey Heart and Vascular Center to go and teach. But this is really very important in addition to everything else that we do. This is the trend of cardiovascular mortality. You've seen this. This is an older publication, right? And we've done tremendous impact on cardiovascular mortality, multifactorial. You could see the timing here there. But if you wonder where we are nowadays, and this is the latest data from the CDC, if you wonder where you are nowadays compared to other diseases that other leading causes of death, you could see that heart disease has had the most impact going down. Number 2 is cancer, and you could see we're almost rivaling each other as to the leading cause of death. I know many times we say, this is the first time where I'd like to be not number 1, but I'll take number 2, I'll take number 3, I'll take whatever it is. I just don't want to be number 1. But you could take a look at the impact of what has been, right, on cardiovascular disease. It has been really tremendous. And I think, you know, the research, the application, the healthcare system really has improved. And stroke also has decreased significantly. You could see stroke down there. So nowadays we are at 23.4% of the causes of death, and cancer is at 22%. So just imagine what you saw there, right? A significant decrease, and compare that to something that we're doing to ourselves that would negate quite a bit of the impact, the positive impact. This is obesity in the United States from 1994, 2000, and 2015. It is alarming. Do you know that what is the percent of the population nowadays that has, just weight-wise, let's say closer to ideal weight? It's less than a third of the population. So 1/3 is obese, 1/3 is overweight, and 1/3 has closer to. And the impact of that is on diabetes also. You could see that. It's amazing, right? So it is no surprise that the curve of decreasing in mortality has almost plateaued, and I know this past year has stayed the same and actually may have an uptick a bit. So this is an issue. This is an interesting diagram, okay? So this is health behavior. On the right is ideal health factors, okay? Like risk factors. And on the left is number of ideal health behaviors, okay? So ideally, you'd like to be in that little tiny first column. That little tiny first column, which is less than 5% of the total population. Less than 5% of the total population. And take a look at the ones with zero ideal health factor as well as zero health behavior. It's amazing. So we have a lot of work. Now, there was an initiative, I talked to you about it in 2011, called the Million Hearts. And this is a governmental initiative to save 1 million hearts from death. Okay? And that was in 2011, so the end point was 2016. We don't have all the data, but I'll share what was done. So in 2011, half of the population was taking aspirin appropriately. Blood pressure control was about 50%. Now you think about your patients, they're controlled, right? And the vast majority may be controlled. But these are the ones who come and see you. Just think about the ones who don't come and see you. Cholesterol, appropriate cholesterol medication, a third. Smoking, 23% now is down. Okay? So I want to share with you the impact of this initiative, which involved so many people, so many organizations that you won't believe. Blood pressure control, we're up from 48 to 55%. Statin use among eligibles, almost 60%, better, no question about it. Smoking prevalence has gone down, which is also better. Sodium reduction stayed about the same. So this is the analysis that I would take to bullet number 2. We estimate that up to 500,000 events, not 1 million, 500,000 may have been prevented from those 5 years. And it involved 120 official partners, 20 federal agencies, and all 50 states and Washington, D.C. A mammoth work with, yes, some impact, but it can tell you what the magnitude of this will be to be able to impart change. And, you know, they're not stopping there. I think this is great because they're thinking about the next 5 years along the same line, but also many other agencies are really looking forward to do many things regarding health and population health. And they will be under the quality payment. These ABCs that we talked about, aspirin, blood pressure, you know, cholesterol, will be part of the measurement. And last, I wanted to share with you, you see, you remember this curve in the United States, how it's gone down significantly? The curve in the world is in the opposite direction. So on top is cardiovascular disease. It is projected to increase globally as opposed to decrease. And notice also the difference between cardiovascular disease and cancer. Cancer is in green, right? So more than double mortality and morbidity and so many other things in this situation. And this is the distribution. The distribution in the world, you could see it. It is affecting quite a bit of Eastern Europe, Africa, etc. And what are the areas? The areas of risk factors are the ones that we know very well: tobacco, blood pressure, glucose, etc. You know about the 25 by 25 initiative from the United Nations and World Health Assembly, and we were quite involved in that, and these are also the presidents of WHF, American Heart Association, and European Society of Cardiology. And basically, in the world, the directives are to try to have a reduction in salt, blood pressure control, better blood pressure control, obesity, sodium, et cetera, and try to decrease the incidence by 25%. And what we did, actually in collaboration with the University of Washington in Seattle, is to take a look at modeling and have an idea of, if you affect these, what is your best buy to try to affect cardiovascular disease? And I'll share that with you here. This was published in Circulation last year. This is the probability on the left and its course over time. And if you did an intervention, these various different colors that you see on the right, is if you do all the interventions in green, yes, you'll be able to reduce it by 25% by the year 2025. But the most impactful is blood pressure control, which is in the magenta red color. That's the most impactful. If you control blood pressure, there are so many other things that actually you would impact mortality, morbidity, and you name it. And if you want to take a look at divergence in the world, this is high-income countries. They start at a low probability to start with, and yes, you can improve it by 25%. But look at Eastern Europe and Central Asia, where their probability of disease nowadays and probability of death is incredibly high. It's almost, 2 or 3 times, the Western world and the high-income countries. And how we're able to do this? Yes, you have all these directives and everything else, but you don't have really the manpower to do it. It has to be affected at a local situation. And I and several of you have been involved in the ACC to try to do many things, many other initiatives in the world. Now we have 40 ACC international chapters. It's education, it's teach the teachers, and et cetera, to try to affect care. You're not going to be able to invest dollars amount. I think education is important to be able to do that. And part of the education actually is the ACC have regional conferences now for prevention and the latest in cardiovascular disease education. I've been privileged to be tapped to do this for 3 years. And the next one is in Dubai for the whole region of the Middle East. And last but not least is you have to think about the next generation of leaders who will take this and carry on the mantle to think about prevention of cardiovascular disease, not only primary prevention, secondary prevention, appropriate care, health care, be it in this country or the alike. And there is at the ACC, there is an International Leadership Academy. These individuals that you see on the right have been picked from various regions of the world, 35 leaders that have been picked by each one of the country to come and interact for about 2.5 days and go back to their countries to gradually put the seeds towards better healthcare. Now, I want to leave you with this. We talked about applied science here. Now, if you tell me, how can you move the needle? To tell you the truth, I don't need any new research. I need to have applied systems. As you could tell, if I can control blood pressure, even in this country, I will move the needle in a major way. So yes, you have to think about that. You have to think about healthcare systems and how do you act towards patients and reach the population at large. Hopefully they can have access to care. But the beauty of our field and medicine is that it keeps growing, it keeps innovating. And I think these innovations are great for discovery and ultimately to apply to patients. So I wanna leave you with this. Disruptive dozen. I don't know how many of you have heard about it, but this is the World Medical Innovation Forum that is put in Boston from the various organizations in Boston and involves world leaders in various areas, and this is for cardiovascular disease. And this is the latest one, 2017, and this is targeted for cardiovascular care. And the question is, what are some of the disruptive areas that we need to think about for the next 10 years so that could be conceivably doable? could be impactful in cardiovascular medicine. So I want you to think yourself is what would be important things that you'd like to tackle within the next 10 years? Maybe beyond your field. Michael, maybe beyond the field of a catheter-based, valve replacement. I think it'll be very interesting for us to think about that, okay? And I put them in order. These are the disruptive dozen. Number 12 was aging and heart disease. Can we reverse the process? And I'll make some commentary because I think, Dr. Cook is working on the aging process in a way, so I'm just, trying to give it a local flavor. Nanotechnologies for cardiovascular diagnosis and treatment. And we certainly are a center renowned for that with the Costas, grant and involvement and endowment, and Dr. Ferrari's team on nanomedicine. Breaking the code, diagnostic and therapeutic potential for RNA. I know Dr. Cook has an RNA laboratory now, and I think it is really important to start thinking about that. Expanding the pool for organ transplantation. I know our heart failure colleagues certainly think about that, and maybe about different, organ transplantation. May not necessarily be from human to human, so hopefully that will expand down the line. Finding cancer therapy without cardiotoxicity. I know we have interest in this with Barry Trachtenberg. Less is more. Minimalist mitral valve repair. And I know with Dr. Lowry, we have really pioneered mitral valve preservation in mitral valve repair. Understanding why exercise works for just about everything. It does, but we don't understand it. Power play, the future of implantable cardiac devices. And I think that speaks for heart failure, electrophysiology, you name it. Adopting the orphans of heart disease, targeting inflammation and cardiovascular disease. And I think if you tell me what is the big new frontier, the data at ESC was quite impressive. This is the first time where you could see that if you target inflammation alone in patients who have higher CRP, the impact is tremendous. And I think that that's a new target nowadays that we're thinking about. Harnessing big data and deep learning for clinical decision support. This is something that we really need to be in. As I shared with you last year alone, there were 92 companies, new companies, that are looking at AI and deep learning. And at our next MMI meeting, the multimodality imaging meeting, we're going to bring some engineers telling us about artificial intelligence and how does it apply to us. And last but not least, quantitative molecular imaging for cardiac phenotypes. I think it's an impressive list to just widen our imagination of where does the field go within the next 10 years or so. What are areas of investigation? What are areas of development that we'll be on the lookout for? It really is an exciting time. And in cardiology, cardiovascular care, we have a lot of challenges that I shared with you, particularly even on the basic level of health care. But I think the field is really amazingly exciting for new discoveries, but I think we have to be as excited for the new discoveries as to try to improve health, because if our mission is to increase longevity and good quality of life at the same time, we really have to think about that in addition to all the tools and all the innovations that we have. So thank you for the opportunity to come today, despite many things going on in Houston, and look forward to interacting for the next year. Thank you very much.
Bill, your talk was well worth getting up at 5:30. And I love your list of disruptive dozen. Every single one of them is an extraordinarily expensive technology. My question would be, in our insistence upon cost control, which is the current era, are we going to be able to afford, and will we be able to afford the incredible expenses to develop these technologies?
I think it's an important question, but if you look back, Al, at many of the innovations that have occurred over the past few years, they have been expensive. Catheter-based replacement of valves, the newer anticoagulants that have added not only convenience but safety to patients at the same time. Yes, it will be expensive, but I think it is our healthcare system and our population that we have to think about. Obviously, if it is purely redundant, and just more expensive, we know hopefully we're not going to go for that. But if it adds value, if it adds better prognosis, better quality of life, I think we have to make that decision, payers and basically our healthcare system, we're going to have to do that. But I think it's very exciting, and this is part of our evolution. And I think the market and our decisions will make that decision and determination.
Bill, first of all, thank you very much. It was a great start for the academic year. Let me ask two questions. One is around the various different registries that you have in the ACC. What don't understand is public reporting of that data. And I bring that up really from the point of view of STS began to improve quality. And then a year ago it was, we would like you to report your data by surgeon publicly. And then the following year was, you will get extra points in US News and World Report if you report it, and otherwise you lose points if you don't report it. And so it has kind of moved from being, let's improve quality, to public reporting by physician venue. We have voted to do that actually at the service line meeting. And so next year we will be reported by surgeon what the outcomes are. Now, I'm not sure where the ACC is in this, but I'm sure a lot of people are potentially concerned about it.
Public reporting nowadays has evolved. I can tell you from an ACC perspective. There was a paper written about almost 10 years ago, and I think still stands, that the public reporting would not be at an individual level, it will be at an institution level. Now ACC is reporting through CardioSmart. So if you go through CardioSmart and take a look at hospitals, you will see our hospital, our neighboring hospitals, it is voluntary, and it is for interventional procedures as well as an ICD registry. We've done okay, and I think we will hopefully do better. It is important nowadays. I really think it's important to do something, maybe not at the individual level. ACC is not advocating to report at an individual level. But I think it's a good idea to report publicly, and the reason for it is there are so many other reporting that is rather bogus about you as an individual or your institution. And I think if you have data to show that you're really good, I would show it. And at the same time, if we're not doing well, and I'm not talking about only the process of recording whether you're taking this medication or not, I'm talking about the important ones down the line, adjusted for mortality, for risk, et cetera, et cetera. I think this is the most objective data about your institution that you should be reporting. So the ACC has nice things as to what should be reported, and it would not be at an individual level. So I don't know if STS is still going for the individual level. Now, internally in service line meetings, I'd like to be as open as possible, because we can learn from each other. We can learn from each other regarding, procedures, outcome, documentation, and part of the burnout is actually not use the technologies that we have in the most efficient and effective way. All right. Well, thank you very much, and have a great day.